All right. Well, hello once again, everyone. Welcome to the Pearls Lecture Series 2023, or welcome back. Once again, my name is Bilal Hafiz. I am a third-year medical student at the University of Melbourne. And before we get started, I'd like to quickly have a chat about Pearls as an organization, like we usually do for those that are new to our group today. So Pearls stands for Focus for Emergency and Acute Care in Resource-Limited Settings. Last year, we had our inaugural Pearls course in Port Vila, Vanuatu, where Vanuatu doctors received handheld ultrasound probes to plug into their smartphones, and they undertook 3 days of ultrasound training from a visiting team of sonographers and Australian ED physicians, including the head of Pearls, Dr. John Henry, who's part of our audience today as well. Now, we've run some additional programs since then as well, and Joe has actually been a big part of that. So we're really happy to have her here, come back and have a chat with us on some new and exciting things, but also some review from the past. So after that course was done, and since these courses have been done, doctors continue to receive feedback via remote imaging techniques. And then since then, the Pearls Lecture Series was also put into place so that we can continue supporting these physicians with their healthcare professions, as well as keep on upscaling and training them as well. So we'll be kickstarting our 6th lecture of our series today, being Obstetric Biometry, given to us by Joe McCann. So, Joe, we understand that you have a variety of experiences in clinical as well as academic role in teaching clinical ultrasound as well. So it'd be really interesting if you could let us know how exactly you kind of got into ultrasound and how you've made it a big part of your practice, both in the clinic, but also in terms of education as well. So if you can give us a quick rundown on your experiences and your history with ultrasound, that'd be great.
Sure, thanks, Bilal. So I actually fell into radiography. I was quite good at science and wasn't really sure what I wanted to do, and had seen someone taking x-rays. So I thought, oh, that could be quite interesting. And I liked the fact that you weren't actually only restricted to x-ray. There were opportunities after you graduated. So I did an undergraduate degree in radiography at Auckland Hospital, and then right from the very start, I knew I wanted to do ultrasound. So I had to complete 3 years of radiography and then take a wee while to get an ultrasound training position, because they're very hard to get, and then undertook 2.5 years of study postgrad to become a sonographer. So there's a lot of training involved in New Zealand and Australia to become a sonographer. And from there, I've worked in public and private hospitals throughout New Zealand, Australia and Canada. And I was always quite interested in education, and I ended up teaching sonographers in Auckland, and I set up the program at Auckland University. And now I've sort of gone on down a little sidetrack, and I lecture at Otago Medical School for the point of care ultrasound program, which I really enjoy. And one thing I've always has been very important to me is to give back to the profession that I work in. And so that's what my big focus on outreach is. So not only do I help Pearls, but I'm the program manager for RadAid in South Pacific. I'm a director for the Australasian Society for Ultrasound and Medicine, and so I'm involved in their outreach programs as well. So I've got quite a busy life and quite a varied work-life balance. So it's actually really good. I've got lots of fingers and lots of pies, and that's what I like about it. And I just love ultrasound. Even after 20-something years of doing ultrasound, I always find there's something new and something interesting to do in my field. So it's never boring, and it's a really interesting profession to have. Thanks, Bilal.
Well, thanks so much for sharing that insight. And I think it's gotten everyone a little excited to hear more about your lecture today because of your breadth of experiences and the specific personal insights you bring about ultrasound as well. So without further ado, please do get started. And once again, everyone who's joined us today, please do hang around after if you'd like to have a discussion or more questions as well after Joe's done. But yeah, Joe, you can take it away now.
Lovely, thank you. So I've been asked to talk to you about ultrasound biometry, and I know that Grace has spoken to you recently about this, but we thought we'd do a bit of a recap and maybe pull in some of the butterfly images and talk about how we can perform these scans using the butterfly transducer. But before I start talking about ultrasound, obstetric ultrasound, one thing that's really important to sonographer is ultrasound safety. So ultrasound's been around for many, many years now, and we haven't found any problems with it. But you'll find that sonographers are always very careful about ultrasound. And we practice using the ALARA principle, which is as low as reasonably achievable. And there are a few things that we do that help us achieve that. So for a pregnancy ultrasound, we would always use the appropriate pregnancy preset. So that would be first trimester if we're doing an early pregnancy, or second and third trimester for the second and third. We talk about dwell time, so that's how long the ultrasound transducer stays in one place. If you ever get to see a sonographer scan, we're always moving our transducer. So we're never sitting in the one spot. So we're always moving that ultrasound energy around. We wouldn't use Doppler ultrasound in pregnancy. And one thing to consider, and I know that people get very excited if their partners are pregnant or their friends pregnant, and they often want to have a wee scan of their baby, but we would be scanning in pregnancy only when it's medically indicated. So that's something to consider. Is the examination that you're about to perform medically indicated? And the safety parameter that we use is the thermal index. And by using the appropriate preset, making sure it's medically indicated, thinking about dwell time and no Doppler use, they all help to keep that thermal index less than 1. So the first part of my talk today is going to be about early pregnancy, and those who were in Vanuatu last year, this is very similar to the talk I gave to you with the Pearls program there, and those joining me from Tonga as well, I gave a similar talk there. So it'll be a bit of a recap for you, but hopefully you still get some interesting points out of it. So there are a few structures that we look for in early pregnancy, and in the point of care ultrasound field, you mainly use transabdominal ultrasound, which makes it much harder for you. As a sonographer, both Josie, I can see Josie's online as well, we would use transabdominal and transvaginal ultrasound. So it's a little bit harder when you're only using transabdominal ultrasound. But the first structure we're going to see in pregnancy will be a gestational sac, and we'll see that at about 5.5 to 6 weeks. But that's always depends on patient habitus as well. If you've got a very large patient, that might be take a little bit longer to see that. We're going to be looking for a yolk sac, and I'll talk about all these structures as we get through the talk, so you'll be able to recognise what they look like, and we'd be looking for that or expecting to see that around the 6 to 6.5 week stage. Your wee embryo, we should be seeing that about 7 weeks, and cardiac activity in limbs we'll see about 7 to 8 weeks as well. Now, we're fortunate that we have beta HCG testing that's easy for us to access, and those are the beta HCG parameters that we'd expect to see those structures at. But I understand that that's not always possible in an outreach situation. There are a couple of landmarks that we hope to see. And that's quite useful for you when you're trying to find a gestational sac and you're starting out. Now, if you have a look at here, this transducer is in the long axis, and the marker is pointing towards the patient's head up here. And this is what we're going to see. So the first structure here is the symphysis pubis, and that's a really good, useful landmark. Even if you're doing a fast, or if you're doing a pelvis or a pregnancy, we want to see that wee bony little wee disc there with the shadow behind. So that's because the ultrasound's hitting the bone and going back towards the transducer, and the ultrasound doesn't pass through that. So that's the symphysis pubis. So look for that shadow in the longitudinal plane. This is the bladder, the triangular part here. And then this is the uterus here with the large fetal head here. Now, your landmark in short axis is actually the vagina. So here we are, we're in short axis here, or transverse plane. The marker is towards the patient's right in the ultrasound machine. And this is what it looks like. It looks like a little flat wee disc. So that's your landmark there in the short axis view. Now, when we're performing early pregnancy ultrasounds, the structure that's really important to us, and the landmark we should be looking at internally, is the endometrial stripe. Now, this is a longitudinal axis, so the marker's towards the patient's head. This is bladder here. The symphysis pubis would be sitting about here. We can't quite see that. But this is the vagina through here, round to the lower uterine segment and the cervix, and up around the fundus of the uterus here. So the structure that we really want to see is the endometrial stripe. So here it is here. This is the vaginal part of it, into the cervix, lower uterine segment, and we can see round here, this is the fundus up round here, and we can see there's a gestational sac there. So really what you're looking for is the tick, and we can see this here if we overlay it. So try and make sure that you can connect all these things up when you're looking for an early gestational sac. So the majority of your patients will have an anteverted uterus, so this way, and that's much easier to find the gestational sac. But some of your patients will have a retroverted uterus, and we can see here's the vaginal endometrial stripe, the cervix, lower uterine segment, and this is the fundus of the uterus. So it's tilting back. And that's really, that can be quite challenging to see that gestational sac there and see any contents. And I think Josie would agree with me that even in our, we have large, very expensive machines, big machines, and we'll struggle sometimes to see the contents of a gestational sac scanning transabdominally. Now, I've mentioned this word gestational sac. So what does that actually look like? So this is it here. We're looking at a gestational sac here. So it's anechoic. So that's a word we use to describe something that hasn't got any internal echoes. So it's black. So a bladder would be another example of something that's anechoic. But here's the gestational sac here. We've got a round structure here. It's going to be slightly off to one side, and we're going to see a decidual reaction around. So it's a little bit like a ring donut. So here's one part of it, and here's the other part of it here. So it's this structure here, and you can see that it's echogenic, or it's, brighter than the surrounding structures there. And that's what we call a decidual reaction. And that's important to look for that to see if the structure that you're looking at is a decidual reaction, or maybe it might be what we used to call a pseudosac or intracavity fluid. And that's what people look for if you're trying to decide whether it's a gestational sac or an ectopic pregnancy. But really, I think you need to look for that bright echogenic ring, which is the decidual reaction. And although we can't see a yolk sac here, probably fairly certain that that's actually a gestational sac. Now, the next structure that develops is the amnion. Now, this image down here is really bright. I've overgained it to help you appreciate there's a wee amnion through here. You can just see that wee ring there. And here it is here, the amnion here. So that's the next structure we'll see. And this round structure here is the yolk sac. So it's round and it's echogenic. And it's sort of like a circle within a circle. If you think of the gestational sac being a circle, and then you're looking for that other smaller circle within. And that once you see that yolk sac, you can be certain that that's an intrauterine pregnancy. So you've had a wee look with your ultrasound and you found a gestational sac, and you're thinking, okay, that's great. What do I do next? So what you need to do is look carefully to evaluate the contents. So you're going to be looking in longitudinal plane and transverse plane as well. So borders, boundaries, and beyond in 2 planes, and looking to see if you can see anything inside it. So if you can't see anything inside it, you're going to measure the mean sac diameter. And I'll talk about that in just a minute, about how we do that. And if you then see the yolk sac with it inside it, the measurement that you perform is still the mean sac diameter. But once you identify an embryo, and here's wee one here, there's a wee head, a body down here, and we can just see a few wee, the limb buds starting there. You're going to measure the crown rump length, which is from the top of the head to their bottom. And we're also going to, once we see that, have a think about whether we can see viability. So can we see a heartbeat? And you might measure that using a clip, just record a cine clip, or you might use the M mode as well. Now, I've mentioned mean sac diameter, so that's a wee measurement of the gestational sac. And we're going to see that about 5.5 weeks. And what you need to do is obtain a short axis view and a long axis view. And we're going to take 3 measurements. So it's inner wall to inner wall. So here's the longitudinal plane, and here are the 2 measurements in the transverse plane. And then your machine will calculate a diameter from those 3 measurements. And that's the measurement that we do if we cannot see an embryo or a fetal pole. And when you're using your butterfly, this is how we do it. So we're going to use this button here, which is actions. And once you click that, you'll find it will bring up the next menu, which is the mean sac diameter. You obtain your image and you freeze it and press more actions, and then you'll be able to select your first measurements, because remember you're going to do 3 measurements, and this is how you do it. So inner wall to inner wall. So it's the crosses that you're going to put, the inner wall to inner wall, and the blue circles for those who haven't used their butterfly to do a mean sac diameter. That just helps you elongate and move your measurements around. And you can see in this butterfly image, you can see that decidual reaction. You can see that donut look that I mentioned earlier. Then you're going to unfreeze, and then you're going to obtain your 2 other measurements. And then we select this button here, which will bring up your report, your exit and report, and this gives you your mean sac diameter and your average ultrasound age. But remember, this doesn't actually confirm an interuterine pregnancy until you see a yolk sac. So once the early pregnancy gets a little bit further on, we may be able to see an embryo. What we do when we see that is perform a crown rump measurement, which, as I said, is from one end of the embryo to the other, so from the top of the head to the rump. And we don't include the yolk sac or the limbs, and that can be a little bit tricky sometimes, so we might need to make sure that we fan all the way through, and what we're seeing is the top and the bottom of the little wee embryo. We want to have them in neutral position. When they're this little, it's quite easy to get them in neutral position, but as they're getting up to about the 10, 11, 12 week mark, they tend to curl a little bit. And you're going to measure the long axis. Now, that's not necessarily in the longitudinal plane or the transverse plane. You'll need to have a look through in both planes and figure that one out. So we can see baby's head here, body, and we've got some limb buds here, but this one here is much earlier on, and you can see it's just a wee little, what we would call a fetal pole. And so to perform that measurement on your butterfly, again, it's the actions. Select the crown rump length this time. And here's the wee embryo here with the vitelline duct and the yolk sac here. And we're going to measure from here to here. So you're going to select your crown rump length and do your measurement. Once you've repeated that a couple of times for accuracy, you press this cross here, which will take you out of that field, and it will give you an exit and report. And here we go, there's your report there with your average ultrasound age. Now, one of the things that we need to think about is viability. Now, as a sonographer, I always used to do an M mode here, which is the trace of the heartbeat. But now that I've done more and more point of care ultrasound teaching, I actually think a wee cine's enough. This is a wee recording, and I think we can all see that that's the little embryo that's moving, and be quite comfortable with that to prove viability. If they're a little bit smaller like this is a 6-week little, or 5-week little, 5.5-week little embryo. But you can see just in here, you can see a little bit of flicking, and that's proving heart rate there and viability. So you do have options other than an M mode, because M modes can be quite tricky. You need to line up on the heart and keep still and select the heart rate. So it can be a little bit tricky to catch that. So certainly cines, I think, are fine. And so on your butterfly, again, you press your actions. If you want to do an M mode, go into M mode here, and you'll see there's the wee blue button, and you need to line that up on the fetal heart. And you can see that this embryo is quite little, so it might be quite challenging to do that. Line that up, and then select line. And once you freeze it, once you have that lined up and select it, you then get the 2 traces here. So you get the live image of the embryo with the trace, and then you have to freeze it, press line, and then measure between the 2 peaks there, and that will give you a average rate. Okay, so that's sort of a little bit of background and a little bit of measurements. But what I'm going to do is talk to you about how actually I perform an early pregnancy ultrasound. Now, I understand that often patients for you may present much later in the 2nd and 3rd trimester, but you may end up having an early pregnancy patient. So I will just run through this very quickly, and then we'll get on to assessing the 2nd and 3rd trimester patients. So for the preparation, if we think about the patient position, we're going to have them supine, and we're going to be looking at that same view that you would do in a FAST. Now, I know most people in emergency department will know or understand how to perform a FAST scan. So if you just think about the view that you're getting will be the pelvis, like when you're scanning the pelvis. And so the patient's going to be supine. If they've got a full bladder, that's really helpful, but sometimes they can't. That's not possible in a point of care setting. The patient may have come into the emergency department and they may have had to do a urine sample and do the pregnancy test that way. But if possible, a full bladder is very helpful. Slip their trousers down, and often that's a little bit further than what they think the trousers need to go down, and also down at the back as well. Otherwise, you find that the trousers come up and you're sort of fighting the trousers, or you're scanning the trousers, and it just makes it a little bit tricky for you. Please make sure you've got the correct preset, and we can see with the butterfly, it's the OB1 gynae preset. And the other thing I haven't really talked about is your optimizing of your image. So we're thinking about the depth, focus, and gain. And the correct depth makes the structure that you're looking at as big as possible, but also ensuring you get all the information on it. The focus you can change on your butterfly, so the focus should always be at the area of interest. And what that does is it narrows your ultrasound beam down, and so you get really good resolution right where the ultrasound beam is narrow. And gain, of course, I think when people first start, it's very bright, and then they tend to go to very dark. But sometimes, try and get it in the middle there. So what I'm going to do is just chat to you about how I perform an early pregnancy ultrasound. So my point of care question is there an interuterine pregnancy? And sometimes that's a bit harder to figure out than what you think. So I like to start really wide, and I sort of think of it as my global overview. So I'm going to get the wide stuff done first, the sort of not that exciting stuff, and then move into the center of the pelvis. So if we think about out wide, what's out wide? Well, what sits out there are the ovaries. So this is a view of the right adnexa with the right ovary here. So we've got the iliac vessel here in the longitudinal plane, and here's a wee ovary here. And a lot of people sort of think of that or use the analogy of a chocolate chip cookie, because we can see little black areas here, which are the wee follicles, and some people liken those to chocolate chips in a cookie. So that's lovely if you see the ovary clearly like that, but I'd have to say a lot of the times I don't even see that. And that's with my big machines and with a patient with a very full bladder. So here's the full bladder here. This is the uterus here over in transverse plane with the endometrial stripe here. And here I'm looking through here, trying to find an ovary, and I actually can't see one, but what I can see is a lot of bowel gas and not much else. And that's actually quite normal. So I've just got a wee scan here. So here I am over in the right adnexa. This is uterus here, bladder here, and I'm scanning up through here. And I'm not sure if you can see that ovary. It's just sitting in the middle with the wee follicles around the edge. So I'm sure you're saying, so why are you interested in looking at the ovaries? Because actually you want to figure out whether there's an early, an interuterine pregnancy. So really what I'm doing is trying to exclude an ectopic when I'm out to the side. So I'm looking to see if I can identify the ovary, looking to see if there's any free fluid, and looking to see if there's a big adnexal mass. So something that might be an ectopic pregnancy. So once I've done the right side, I pop across to the left side. Now, this is a different patient than the one I scanned previously. This is the uterus here, and this is the ovary here. And I'm not sure you can appreciate, but there's a little bit of free fluid there. So here we go here, some free fluid through there. So this is the bladder here, which is very full, and it's got lovely round edges. But you can see down here, the fluid or the anechoic region down here is quite pointy. And that's the thing about free fluid, is it often has quite sharp or pointy edges because it fills into the spaces rather than actually being inside a space like the bladder is here. So in this case, I can see there's free fluid, so my suspicion for an ectopic pregnancy will be raised. It doesn't tell me there's an ectopic pregnancy, but I've sort of got a warning flag up thinking, okay, what's happening here? So once I've had a look out at the adnexas, I'm going to move in and have a look at the uterus, which is in the center of the pelvis. So longitudinal plane, I've got the marker towards the patient's head. And just to remind you, I'm looking from the symphysis pubis, the bladder, and then the uterus here. And so here I am, I'm scanning through. We've got symphysis pubis over here, bladder here. This is vagina here, round to the, I'll just wait for that to come up here. This is the cervix and lower uterine segment, coming up around the fundus of the uterus and down here. Now you can see that I have a little bit extra depth here than what I would if I was only looking at the gestational sac, but you remember I'm doing my assessment, so I'm doing that overview, and I'm looking in the pouch of Douglas for free fluid, and this is where I would see it down around here, first of all, in that longitudinal plane. So I'm looking to see, is there any free fluid there in the pouch of Douglas? I'm fanning all the way through and out the other way and back again. So I'm doing borders, boundaries, and beyond. And I'm looking here at this gestational sac. How many gestational sacs are there? And how many embryos are there? So at this stage, looking at that more broadly, I think there's one gestational sac and one embryo in there. And then I'm going to turn into the short axis. So I've rotated the transducer 90 degrees. The marker is now towards the patient's right in the machine. And you'll see there's vagina there, and I'm coming all the way up through the uterus and out the other side. So I'm repeating that borders and boundaries and beyond in that other plane. And I'm looking to see, can I see any free fluid? How many gestational sacs can I see, and how many embryos can I see? And can I see a moving embryo or fetal heartbeat? So that's that global overview. And then I focus in on the area of interest. And so for this scan, it's actually the gestational sac. And you can see I've reduced my depth now, and I'm really just focused here, having a look to see what I can see there. And I'm just repeating that borders, boundaries, and beyond. And in the short axis view, having a really good look there to see what I can see. So once I'm happy with that I can see an embryo or I can see a gestational sac, I'm going to do some measurements. And that will be reflective of what you see in that gestational sac. So in this case, I'm doing a crown rump length. This is the embryo's head and their bottom there, so doing a measurement along here. And this is the gestational sac. So those three measurements, inner wall to inner wall. So if I see an embryo, I just do the crown rump length. But if I can't see an embryo, these are the measurements I need to take. And then I'm going to record viability as well. And in this case, I've just recorded a wee cine loop to prove that. So that's all very well and easy if you see an embryo within the uterus, but what happens if you don't? So this is the longitudinal view of the pelvis again. This is the bladder. We can see that we can round areas here, round curved fluid, and this is the uterus. So this is vagina, around to the fundus of the uterus, and around lower uterine segment cervix, round to the vagina again. And the structure that I'm looking at is the endometrial cavity. So I'm following it along the vagina here and around and up to the fundus of the uterus. And as I follow my eye around there, I can see that I can't see a gestational sac. So now I've got a pregnancy of an unknown location. And so this patient has a positive pregnancy test, but I can't see an IUP. So I can't see an interuterine pregnancy, and I can't really see any retained products of conception as well. So these ones are quite tricky, and these require a follow-up. So we may be too early, maybe too soon to see anything on ultrasound. Might be an ectopic pregnancy. And if we look up here, I don't know if you can appreciate, there's a little bit of free fluid up here, and that's got those pointy edges again, or the pregnancy is ended. So we need to just follow that and see what happens. So ectopic pregnancies can look quite different depending on what state, where they are and how far along they are. But really, you're going to see an empty uterus. So just like we saw back here, I can't see a gestational sac here at all. We're not going to see a decidual sign. So that's that echogenic ring. We don't see that. Now, when I was a student, I learned about pseudosacs, or what we now call intracavity fluid. But if we have a look at that figure, only 10% of ectopic pregnancies have that. So that's a really tiny number. So I'm not sure that that's really a reliable predictor of an ectopic pregnancy. But what we're looking for is fluid in the pouch of Douglas. And we can see there's if we look at this, here's the uterus here. We can see some fluid here in the pouch of Douglas, and we can see some fluid along the top of the uterus here. And you may see an adnexal mass separate to the ovary. Here's the ectopic sitting there. but we also need to have a look at fluid up in Morrison's pouch. So if you think about those fast views that you've been doing, here's the liver, tip of the liver here, there's the kidney there, and look at those pointy edges to that free fluid in Morrison's pouch. So this patient here has got fluid in the pouch of Douglas, fluid in Morrison's pouch, and has an adnexal mass as well. So this is positive for an ectopic pregnancy. So just before we leave early pregnancy, I do just want to point out a couple of things to you. So the Australasian Society for Ultrasound and Medicine have some standards of practice on their website, and these are free access for everyone throughout the world. And they're aimed at sonographers, obstetricians, anyone that uses ultrasound. But I think there's probably a little bit too much detail for point of care practitioners, but I still think they're useful to have a look at. So this one here is guidelines for parent-centered communication and obstetric ultrasound, and well worth a look because it really identifies some key phrases that you can use when speaking to your patients. And I think some of the language around early pregnancy or pregnancy loss or fetal abnormalities is, you need to be quite careful with some of your language. So you might find some ideas there. The other one that I recommend you have a look if you are doing first trimester ultrasound or early pregnancy ultrasound is guidelines for performance of first trimester ultrasound. And that also deals with pregnancy loss, which of course is a very difficult situation. I think it's quite fraught. Can be fraught for me and as a sonographer, but particularly fraught for point of care practitioners. And if we were to have a look at those guidelines there, the ASM or the guidelines say that, first of all, you need to be using high quality transvaginal ultrasound equipment, which in point of care ultrasound they tend not to use, and an experienced operator. And now that's someone, certainly as a sonographer trainee, I had to perform 150 first trimester ultrasounds to be considered beginner level as a sonographer for early pregnancy. So it's really actually quite a large number of ultrasounds. And when I first started, we used crown rump length of 5 millimeters, but that's now gone out to 7 millimeters with no fetal heart activity and a mean sac diameter of 22 millimeters and no embryo. So I think my big thing about pregnancy failure is to please be very cautious about interpreting your ultrasound findings, particularly if you're not that experienced in that area. Okay, so that was a run through and a recap for those who have seen my early pregnancy talk. And I'm going to talk a little bit about second and third trimester ultrasound, basic ultrasound. I use a 6-step assessment when I'm teaching point of care ultrasound in the second and third trimester. And so this is what the steps are. Step 1, I do a scout ultrasound or teach a scout ultrasound, look at viability, look at presentation, look at placenta, amniotic fluid, and fetal biometry. So you can see that at no point really do we talk about anatomy, but that certainly will give you a good basis to assess your second and third trimester ultrasound. So I recommend that you start with a scout ultrasound. So basically that's just having a look through the uterus. So now these images are from the butterfly cloud. They have an education series of educational videos, and this is where these images have come from with the butterfly transducers. So you can see that I'm in short axis plane, markers towards the patient's right. And what I'm going to do is do a grid along the pregnant abdomen or pelvis. So I'm going to scan up here, then scan up the midline, and then out to the left side. And then I'm going to do 3 sweeps across the abdomen as well. And the reason that I do that is that it's really important that you figure out how many fetuses you're dealing with, because of course, maybe more than one, and also to check viability and to check how the fetus is lying. So here's a wee cine. So this is down in the pelvis. This is patient's head here and fanning up. And here's fetal heart, and I can see that beating. This is coming into the abdominal circumference area, and this is the pelvis with the bladder and then turn longitudinal plane, and there is the femur length. So this will start again. So here's fetal head. You can see the falx and the thalmuli there coming up around into the chest. There's the heart. I can see that baby's alive. This is the abdominal circumference view with fluid in the stomach and then fluid in the bladder. And then out to that femur length there. So I've had a wee look around. I've seen where the placenta is. Placenta's over here. It's an anterior placenta, and just follow that baby up through, and I can see that there's fluid around it. I can also see there's fluid in the stomach here, and also fluid in the bladder as well. So that's told me that baby can swallow okay because there's fluid in the stomach, and also because there's fluid in the bladder, I know that baby's kidneys are working. So during that sweep through the baby, we've talked about viability. So we could see the fetal heart beating, but if you wanted to, you could do a measurement of the fetal heart. And I've talked to you about how to do that in that early pregnancy section, but it's just the same in the second trimester or third trimester. And then we're going to look at presentation. So for presentation, I mean, in the short axis scanning through, you could see that baby's head is down. But what I suggest you do is you turn into long axis, so the marker is pointing towards the baby's head. We've got symphysis pubis here, bladder again here, and this is vagina coming into cervix here, although we can't see that well because there's shadowing from the bladder and from the baby's head there. You may need to do the caudal angulation, so angle towards the patient's feet to be able to see down into that cervix. And you have a look to see what's actually the presenting part, and also whether there's any placenta in the way between the bottom or the head and the cervix. So this is an example of one that's not so far on, I think about 20 weeks or 25 weeks. So we've got vagina here. We've got cervix here, the endometrial stripe and the cervix. So this is the cervix here. And we can see that we've got baby's head here, and we've got some amniotic fluid here. And if you look closely, this is the edge of the placenta up here. So we can see that the edge of the placenta is a long way away from the cervix, and we've got fetal head there. So we can be comfortable that that's not going to be covering the os. And this is one of the butterfly images showing the measurement of the cervix if you needed to do that. But that's not something that I would do routinely, and I think that would be only be something that I would do if I thought that it was quite short or there was a funnel. Of course, cephalic with the head down breech, and you can have extended leg, or you can have cross leg there, and transverse lie as well. So cephalic, I think that's really tends to be a little bit easier to figure out because we can recognize the skull bones there. So it's usually can be quite easy to figure that. What's happening. So that tends to be someone.
Hi, Joe. Hey, Joe, sorry to interrupt. You're cutting out a little bit. Hi, is anyone else noticing the cutting out, or is it just me here?
And if you follow it, right, that's not very good.
Hi, Joe. Okay, there you go. Now you're back.
Is that better? Oh,
yeah.
Sorry.
Better now. Yeah, just within the last minute, if you could just repeat yourself. Within the last minute, it was in and out.
Okay, so from here, from this one?
Yeah, this will be good.
Yeah, so just let me know, because otherwise I don't know. I'm talking sort of into vacuum, so I'm not sure what's happening.
Okay.
Right, so just going back to this. So this is an example of a cephalic presentation. So we've got bladder here, we've got vagina and cervix here, and there's the fetal head. So I think when the head is down, it's really easy to see because, or recognize, because we've got those bright white lines of the skull bones, whereas this is an example of a breech baby. And we can see that it's a little bit hard. You'll be thinking, well, what is that? I'm not quite sure what that is. There's a couple of white bits and there's a whole lot of grey bits. So if you were to fan up or scan up along that baby, you would find the head up the other end. So if you're not sure, follow the baby and see if you can figure it out. And this is an example of a transverse lie. So this is fetal head here, lying straight across the abdomen. We've got a beautiful profile here and fetal heart here, stomach there, and bladder down here, and spine at the back with placenta at the front. So this fetus will be about 24 weeks, I think. So they still move quite a bit at that stage. So if we have a look at the placenta now, that's step 4 is placenta. So we've figured out, we've had a look at how many there are, how baby's lying. We've looked at viability. We've looked at the lie, and now we're looking at the placenta. So placentas can sort of be anywhere, but the part we don't want them to be is over the os where baby's coming out. So this is a longitudinal plane of the baby. And we've got fetal head down here, and this is the placenta up here. So that's an anterior placenta, and baby's along here. And if you just see this wee example here, that's actually an example of a contraction rather than another bit of placenta there. And if you come back and have a look at it later, that will have settled down, and the contraction will have stopped. And mum won't feel that. That's just what happens during pregnancy. This is an example of a posterior placenta. So if this is the front of mum and this is the back, this is sitting along the back wall of the uterus. So this one's at the front wall and this one's at the back wall. And we can see that baby's head's here, and this is the edge of the placenta. So the os will be over here. So there's a bit of space there. And then the other one that we see is the fundal placenta, and that's it wrapping around there along the side of the uterus. So that's top there, and really have baby. And this is an example that I found on the butterfly education series. So here is an example with the anterior placenta here, and this is the abdomen with the stomach there and spine there, and I'll show that again to you in a little while. So as I said, the part that we're really concerned about is the os, and these are off the butterfly platform as well. So this is a longitudinal view of the fetus, of the pelvis. So the os will be there, the bladder's there, and this is the uterus here. And so we've got vagina and cervix up here. But if we have a look, if we move up from there, we see placenta, and then we see baby. And this is the same fetus in a transverse lie. So we've got placenta all along the back. So this is an example of previa. So we've got placenta covering the os and then baby above that. So that's something that we really want to be able to recognize, because that has delivery implications. Now, step 5 is amniotic fluid assessment. And previously what we used to do is 4 quadrants, but we now do a single deepest pocket. And you can see that I have the transducer in the long axis here, and the transducer is actually upright. And I've just put some marks on there to divide the uterus into, or the abdomen into 4 quadrants. And what you're going to do is just place the transducer here, see if you can see any fluid, pick it up, pop it here, pop it there, and pop it there. But you're only going to do 1 measurement. So you need to assess those 4 quadrants and look for an anechoic, or a bit of fluid that has no body parts in it, no umbilical cord. And we're looking for 1 measurement in the largest pocket, and 2 to 8 millimeters is normal. So these are the ones from butterfly education again. So here we are, we're looking in that the right lower quadrant. And this is the image, the corresponding image, and we can't see anything that looks like fluid. We can just see baby there. And that's quite common as you get further along that baby will sort of be off to one side and you'll find some fluid on the other side. So then we've picked up the transducer, popped it up there into the upper quadrant, and this is the corresponding image. So again, no fluid, but I'm not worried about that because I want to see what's happening in the other two quadrants. Then I have a look in the left upper quadrant and I can see a wee bit of fluid there. I can also see some fluid here. I'm not quite sure whether it's the stomach or the bladder. So that's reassuring as well, that I can see that there's some fluid within baby. And then I pop down to the fourth quadrant here and I can see a lot more fluid. But can you see this wee kind of, they look like little bubbles? Well, that's umbilical cord. So you can't measure there. So then what we did was picked up the transducer, went back to one of the other quadrants that we saw some fluid, and we froze the image, pressed this button to select the measurement, and here's the line, and we're just doing one measurement straight up and down. So it's important that it's actually straight up and down and not going from here to here, and then just that single measurement. So that's how you do a single deepest pocket, and that's a very acceptable measurement for assessment of amniotic fluid. And then step 6 is fetal biometry. And there are 4 parameters that we use when we're measuring fetal biometry. So we look at the head circumference, biparameter diameter. So there are 2 measurements we do of fetal head. We do abdominal circumference and also femur length as well. Now, I know some places only use femur length to assess the gestational age of the fetus, but actually that's the most unreliable one. So we wouldn't do that as a first choice. We would use the head measurements first. And then if baby's head was tucked quite low down into the pelvis, it can be a little bit tricky sometimes to get accurate measurements. Then you'd be relying on the abdominal circumference measurement, and then femur length would be your last one. But really, ideally, you'd want to do those 4 measurements. And so I'm just bringing you back to this wee cine that I showed you earlier. We'll just wait for it to come through the fetal heart. And now we're coming into the abdominal circumference with the stomach plane and then down to the femur length here. And you can see there's a bit of heel tone to get that horizontal as well. So just have a look at the head. This is the head with the folks through there and the thalami. And we'll go on to a slide showing you that. So we're down, because this baby is cephalic, we're down low. And we're looking for that oval view of the head. Now, the folks is a line, an echogenic line that runs through the middle of baby's head. And what we aim for is to this side to be equidistant to that side. And that can be quite tricky. And if it's not, you might be slightly off to one side. So just think about the tilt and the angle of your transducer as well. The other thing we're looking for is the thalami there as well. And let me show you on the next slide what I mean by that. So these are the thalami here, and this is the folks here with the cavum, septum, pellucidum. And so what the measurements we do is from side to side, which is ear to ear pretty much, and we're going to go from the outer edge to the inner edge of the skull. So you can see this bright white bone here is the baby's skull. And you can also see that the skull is oval, not round. And then you're going to measure, put the calipers around the outside, and we're measuring around baby's head as well. So the outer edge of the bone here. And these are the measurements that are off the butterfly education videos as well. So outer wall to inner wall, and then the BPD around as well. Now, abdominal circumference is the next measurement that we would look to do, and that's again in a short axis plane. And what we want to try and do is get the abdomen nice and round rather than oval, and that can be a little bit tricky. And you can see that we've got ribs here and ribs here, and we really want to see ribs on both sides of your image. So this is spine at the back, stomach here, and umbilical vein. And what we need to do is pop the trace around the outside. And we want to include the skin and subcutaneous fat as well. And we want to see the stomach bubble inside. But we don't want to see any heart or kidneys. And sometimes if that's in your image, it can be you're just a little bit tilted one way or the other. Sometimes with mum, you need to roll them on their sides, and that helps you see the image a little bit better. And then the last image is the femur length. And so if you think about the video that I showed you earlier, we're in transverse plane. We came up from the head through the abdomen up to the baby's bladder, and then we turn longitudinal plane on that to obtain the femur length. Now, this is the image of the butterfly education, and ideally you really want to get that longitudinal just so that it's nice. You can see those ends nice and clearly, and you can see the shadow behind that. So you'd be turning longitudinal, maybe heel toeing, so moving one end of the transducer rather than the other, and look for that distal acoustic shadow as well. And then to perform these on the butterfly, we're going to again select the actions, select fetal biometry, freeze, and then here we have all the options up here. So we have femur length here, abdominal circumference, head circumference, and BPD. And pop your measurement on, and then you exit, and then you get your average ultrasound age and a list of all those measurements as well. Now, it's very tricky if you're seeing patients in the second and third trimester and they haven't had a scan and they're a little bit vague about when their last pregnancy or when their last, period is. So often I found that dating was a little bit off when I've scanned people up in the Pacific. So it gives you a bit of a guide, but it doesn't tell you exactly the gestational age, because we can be out by 2 to 3 weeks in the second and third trimester. So it's not very accurate, but gives you an idea of how baby's doing. So I'm just about finished now. So just for my last couple of slides in summary. So with your fetal biometry, mean sac diameter, if there's no embryo present, between 6 weeks and just under 14 weeks, we're going to use the crown rump length. And 14 weeks, once you get past 14 weeks, you're going to do the BPD, HC, abdominal circumference, and femur length, remembering that femur length is the most unreliable biometry factor. And once you get to 24 weeks plus, you're really just assessing the size of the fetus and not the gestational age, because it's really very inaccurate at that stage. And just a reminder about the 6-step approach, and I think that's a really good program to work through. So do your scout ultrasound, check for viability, see what part is presenting. Is it head down or is it breech? Remembering that babies still do change up until probably about 32, 34 weeks, they'll still move, but not much after that. Where's the placenta? And really important to see whether it's covering the os, because that has delivery implications. Is there enough amniotic fluid around baby? And then think about doing your fetal biometry. So thank you very much. That's a really quick run through fetal biometry. But just wondering if you have any questions. And my apologies for the unstable internet connection.